pericarditis and tumors. So before starting pericarditis, what's pericardium? You all know. Pericardium is a
balloon layer.
it's a layer around the heart. Okay. So it's a fibroserous sac surround the heart and adjoining great vessels. The inner one, which is called visceral epicardium or epicardium, visceral layer, which actually attached with the myocardium directly, visceral one. And it's a thin layer of mesothelial cells closely adherent to the heart. So it is just attached to the heart. And then it reflects, the epicardium is reflected onto the surface of the outer fibrous layer. Like for example, this is heart. So this is visceral pericardium, and then it reflects, and then it covers the fibrous pericardium, fibrous layer. So now there are two layers. One is attached to the heart, which is called visceral pericardium, and one which is attached to the fibrous tissue, which is the parietal pericardium. So there must be some space between. That is called pericardial space. Clear? So the space contains approximately 30 to 50 ml of fluid. It's not too much, but this fluid is very important. Why? Because it drains to the right lymphatic or thoracic duct, because continuously the fluid is being made by mesothelial cells. You know, mesothelial cells has a propensity to make more and more serous fluid, and then it is been taken out, drained into the thoracic duct or lymphatic duct. Now, if you see this one. This one, the shining looking thing is a visceral pericardium, which is attached to the heart. This is fibrous tissue, and the layer which is attached to the fibrous one is a parietal pericardium, and the space between this one is pericardial space. Here you can see in a big magnification, this is myocardium, myocytes. This is visceral pericardium. This is parietal pericardium, this is fibrous pericardium, and fibrous tissue of fibrous pericardium. This area which is in between is a pericardial space which has a fluid which is 30 to 50. So it should not increase this amount. Then we call it pericardial effusion if the amount raises. Now what is the function of this one? So the function will be lubrication. Stabilization of the heart. It keeps the heart in one place. You know, the heart is pumping all the time. It can go anywhere, but you have to keep the heart in one place. So they are surrounded by ligaments which keeps the heart in one place. Number one, it protects the heart from mechanical trauma. So if they are holding the heart, so it is also protected from mechanical trauma. Or infection from the adjoining structure. So infections cannot be penetrated easily. It can, as we will be discussing now. So the pericardial fluid function is lubrication, as somebody said. Your heart is pumping. Do you realize that it is pumping? No. It is continuously being pumping, but you don't even realize that something is continuously. And if you realize, that is called palpitation. There are different other causes of palpitation. But normally, if you are sitting and discussing and laughing and enjoying, you don't feel like heart is pumping, right? This is also because of this. And prevention of excessive dilation of the heart, especially during sudden rise in intracardial volume, for example, in hypertrophy or other reasons. So it does not allow heart to expand that much. Restrict the heart in a particular size. Okay. Now there are different etiologies which can cause pericarditis, starting with the infective one, which is most common. So infection can be viral, bacterial, fungal, parasitic. So the important viruses are Coxsackie, A, B, influenza, adenovirus, HIV. Bacterial is Staphylococcus, pneumonia or pneumococcus, and tuberculosis definitely. Fungal, Candida is an important organism that causes. Parasitic will be amoebic. Autoimmune. Now autoimmune diseases can cause pericarditis. For example, SLE. Although you may not see inflammatory reaction, but it's autoimmune. Drug-induced lupus, which is caused by hydroxyzine or furosemide. Rheumatoid arthritis, again one autoimmune. Postcardial surgery syndrome, that is postcardial infarction, Dessner syndrome. This Dessner syndrome, after few months, the patient develops pericarditis. That's called this. Post-cardiotomy means if you manipulate heart, if you do any open heart surgery, that probably can lead to pericarditis. Neoplasm, primary, we will discuss later on. Secondary, tumor is somewhere else, but it is coming into the heart, which is very rare. Direct extension from the adjoining structure, tumor of the lung going towards the heart. Radiation to the, for example, patient had a breast cancer, you are giving radiation for the breast, but the heart is also getting more radiation. Renal failure, uremia is also one of the most common cause of pericarditis. Then we have traumatic cardiac surgery like penetrating a stab wound, bullet injury, or even blunt, non-penetrating. If a person is driving car and suddenly he got an accident, the steering hits the chest and can cause pericarditis. And then idiopathic. So it's better if you go and look for the chart and remember these findings. Maybe you will get a model question, right? Pathogenesis, vasodilation. So translation of the fluid in the pericardium, and that will cause serous pericarditis. Just vasodilation. Increased vascular permeability. Now the protein, extra protein are being leaked. So what will it do? Fibrin, fibrinous pericarditis. Leukocyte exudation. Excessive leukocyte will come. Neutrophil and monocyte will cause suppurative or purulent pericarditis. So these are the different, according to the severity, different pericarditis which you see. Serous pericarditis, fibrinous or serofibrinous pericarditis, suppurative or purulent pericarditis, hemorrhagic pericarditis, and caseous. Caseous, as the name says, caused by caseous necrosis. And caseous necrosis is usually seen in tuberculosis. Sometimes you also see fungus, but majority it is proof otherwise. It is tuberculosis. If you see caseation, what you will say? Tuberculosis. Especially in our part of the world. When I went to US for my fellowship, when I see caseation and epithelioid cell and this thing, I said it's tuberculosis. My supervisor said, how do you say this? So he said, gentlemen, you are not sitting in Pakistan, it is US. You had to be, because it's not common in US, tuberculosis. So we got an extra investigation to call it TB. We doesn't do frank as we do here or in Pakistan. When we see caseation necrosis, epithelioid cells and this thing, we call it tuberculosis. And then if we go ask for the patient go through for AFB, 90% they are positive. AFB is positive for those patients. But not in US. We have to go for the investigation. We have to stay in this thing and then Okay. We'll do one by one. Starting with serous pericarditis. It's produced by non-infectious inflammatory disease such as rheumatic fever, SLE, and scleroderma tumor or pneumonia. So it's not infective one, but on the contrary, because of the increased dilation. Remember the last slide. So that causes a serious pericarditis. Serious, not serious. Serious. The tissue contiguous to the pericardium, that's bacterial pleuritis, may incite sufficient irritation to cause sterile serous pericarditis effusion that may progress to serofibrinous or to suppurative one. So if, for suppose, if the lungs are involved and the pleura is involved, that can probably trigger the pericarditis to change into serous one. Well-defined viral infection, especially like in upper respiratory tract, pneumonia, parotitis, may cause pericarditis. Again, these are viral infection, and viruses, when they come, what cells do you see in viral infection? The main primary cell? Lymphocyte, not neutrophil, even if it is acute. You will see lymphocytes, viral infection. The viral pericarditis occurs as a apparent primary infection and may be accompanied by myocarditis, that is myopericarditis. We will discuss later when we will be discussing myocarditis. There is mild inflammatory infiltrate in the epicardium, consisting predominantly of lymphocytes. You will not see neutrophils here. So in serous pericarditis, if you see some of the cells, that will be mostly lymphocyte. Normally, the things dissolve without anything, but sometimes it causes some adhesions, which is very rare. Normally, because it's a serous fluid, and if the serous fluid is taken out, and the amount, what is the normal level of fluid? 30 to 50. So if it comes back to 30 to 50, so the chances of adhesion is not there. Okay. Then serofibrinous or fibrinous one. Here, this is the second one, pathogenesis. When excessive amount of protein is also coming with the fluid. Two anatomic forms, this is fibrinous or serofibrinous, the most frequent type of pericarditis, and are composed of serous fluid mixed with fibrinous exudate. So fibrin is also there with the serous one. Causes of myocardial infarction, post-infarction Dressler syndrome, the uremia is very important. Uremia causes fibrinous pericarditis. Chest radiation, as I said, if some female had a breast cancer and the radiation is given, can cause rheumatic fever, SLE, trauma, and or follow any routine surgery. Surface is dry. Now morphology, we are looking at the morphology. So the surface is dry if we are talking about only fibrinous, not serofibrinous. Dry with a fine granular roughening of the fibrinous pericarditis. So the surface will be rough. If you peel out the serous, the parietal and visceral pericardium, you will see a rough area. In a serofibrinous pericarditis, more intensive inflammatory cells can be seen because now it is mixed with inflammation, induce accumulation of large amount of yellow to brown turbid fluid. Now, because of this inflammatory process, so it is serofibrinous now. It's not purely fibrinous now. Fluid is made of brown and cloudy because of the presence of leukocytes, as neutrophils or other cells are there, and RBCs and fibrin. So it causes brown color. And with all inflammatory exudate, fibrin will be lysed. So if it is less amount of fibrin and they are lysed with resolution, probably it becomes normal. But usually what happens, fibrin is not lysed that much. So finally you will see organization organized. Means permanently the pleural space are being attached together, organized, and you can see newly formed blood vessels and everything. So if you talk about the organization of the inflammatory cells or inflammatory or outcome, if you talk about organization, that is a permanent damage. Okay. Now this is how it looks like. You can see this brownish area. These are all fibrin meshwork, and if you see under microscope, these are all fibrin meshwork with lymphocyte and neutrophils. These are actually visceral pericardium. This is myocarditis. Now this is also called bread and butter type of pericarditis. Why bread and butter?
That's the most common.
This is visceral pericardium. This is parietal pericardium. The meshwork is between, right? So if you apply butter on a slice and then put another bread on the top, and then if you peel off, you will see a meshwork, right? You will see the same meshwork like this, and that's why it's called bread and butter type of pericarditis. Clear? Okay. Clinical feature, the important one is loud pericardial friction. Pericardial friction rub. How? It looks like, or you can hear like, this is called friction rub. If you hear with the stethoscope, put it here. Normally if you put it here, you will only hear lub dub, lub dub, lub dub, that's all. But along with the rub dub, you will hear lub dub, lub dub, lub dub. So this is called friction rub. So these patients with fibrinous pericarditis will have this rub. Pain and systemic febrile reaction because of the inflammation. They might have even temperature and pain at this area. Signs suggestive of cardiac failure may be present, so you know about it. Collection of serous fluid may sometimes prevent rubbing. So suppose if it is serofibrinous, so there is a lot of space between the parietal and visceral pericardium, so you may not hear friction rub because of that. Okay. Suppurative or purulent. Suppurative, as the name says, what it will be? Pus. Purulent. Suppurative. Excessive amount of neutrophils. Caused by invasion of pericardial space by microbe. Direct invasion. Reach the pericardial cavity by several routes, either direct extension from neighboring infections such as empyema, lobar pneumonia, mediastinal infection, lung, heart, whatever, so they are directly coming from there. Shedding from the blood, septicemia and bacteremia. What is the difference between bacteremia and septicemia?
Septicemia causes like hypovolemic shock.
Septicemia. Yes, they cause. But what's the difference between these two?
It can be bacterial or other source.
Yes.
Septicemia be due to fungal infections.
If there is only bacteria present in the blood without any sign and symptoms, it is called bacteremia. But if you have a sign symptoms, like now there is a chill, high temperature, right? This is called septicemia. So sepsis has occurred and the patient is in a high fever and a chill, right? This is a difference. Otherwise, in both of the cases, there is bacteria. Lymphatic extension. So the lymphatic drainage can go and the bacteria reach the pericardium. Direct introduction through cardiotomy. The surgeon is doing some manipulation or surgery to the heart. Anything, for example, cabbage operation, and probably the instruments were not sterilized properly. This will cause this thing. Immunosuppression, suppression predisposed to infection by all of these. If the patient is already immunosuppressed, then they can be, cause this one. Morphology, the exudate ranges from a thin cloudy fluid to frank pus, about 400 to 500. Just imagine, the maximum quantity was 50. It is now 400 and 500. Big. The serous surface are red and granular and coated with exudate. Excessive amount of exudate is there. Microscopically, the acute inflammatory reaction, which is sometimes extend to the surrounding structure, and they may cause mediastinal pericarditis. Now, the infection of the pericardium is spreading outside. Sometimes it involves the surrounding structure so much that when the heart pumps, it also stretches the surrounding structure. That's really a big complication of it, right? Complete resolution is infrequent because of the massive pus formation. Organization by scarring is usual outcome, so organization is always there as an outcome. Intense inflammatory response and scarring frequently produced constrictive pericarditis. So what happens in a long-term cases when there is organization and fibrosis occurs, so there will be a constrictive pericarditis. The heart will be constrict like anything, and it cannot expand, right? This is how it looks like. Now you don't see any fibrin here. Rather, you can see a lot of pus around the heart. If you see under microscope, there are mostly dilated blood vessels plus a lot of neutrophils, excessive amount of neutrophils. That's why it's called suppurative or purulent. Right? Clinical features. The clinical findings in the acute phase are the same as the fibrinous pericarditis. Sign of systemic infection like spikes, temperature or chill or fever will be there in these patients, right? Excessive of amount of purulent or suppurative inflammation. Then hemorrhagic pericarditis. This is another type of, as the name says, along with the pus you will be having excessive amount of hemorrhage. So exudate composed of blood mixed with the fibrinous and suppurative. So we have all the three things: fibrin, blood and suppuration. Usually you see in malignant neoplasms, spread of a malignancy. So when you do the tapping or cytology, you see a neoplastic cells there. So wherever there is malignancy, not necessarily the heart, the metastatic cell, if they reach pericardium, they start inflammatory reaction which is mixed with fibrin and blood. So in hemorrhagic pericarditis, if you do the tapping, you will see neoplastic cells, right? It can also be found in bacterial infection in the person with having a bleeding diastasis and tuberculosis. So suppose if there is not, 80 to 90% is a cause because of the tumor. But suppose if there is no tumor, then probably you will see that the patient has some bleeding problems, right? Many other problems. It often allows cardiac surgery and is cardiac surgery and is occasionally responsible for significant blood loss or even cardiac tumor. The clinical significance is similar that of fibrinous or suppurative pericarditis. So high temperature, chill, and you will be seen there. Finally, we have caseous pericarditis. As the name says, caseous means if not proved, until proved otherwise, the main cause will be tuberculosis. What is the other organism can cause? Fungal. Remember, there are two things which can cause caseation. One is the tuberculosis, other is fungus, which can cause. So, if it is not tuberculosis, you have done all the tests. The most important test you all know is AFB. In AFB, what do you see?
Blue.
How blue? What blue? Bacteria?
No.
No. What is blue? AFB, we are talking about AFB, means we are talking about acid-fast bacilli. Acid-fast bacilli is bacteria, the tuberculosis. So, what is blue? Yes, there is blue, but what is blue? Background, not bacteria. So, bacteria will be pink. Very nice. So, we stain blue just to give a contrast. So, the best Contrast for pink is blue color. So you just give blue background so that we can easily see acid fast bacilli. Okay. Pericardial involvement occurs by direct spread of the tuberculosis foci from the tracheobronchial lymph node. So surrounding lymph nodes can directly invade. Caseous pericarditis is a frequent antecedent for disabling fibrocalcific chronic constrictive pericarditis. Fibrocalcific. Now this is another entity. That one is probably adhesive one. This one is fibrocalcific constrictive, means when the caseous material they calcify around the heart, they form a cast-like thing, fibrocalcific. It's a hard, mottled thing, and the heart inside usually pumps, but it cannot expand more. You had to cut that fibrocalcific one. You have to, what you call, destroy or take out this calcific thing, otherwise the heart become very much restricted. We will discuss this thing when we will be doing the last topic, okay? It will be discussed. Now we come to the tumor of the heart. Tumor, primary tumor, luckily, of the heart are very, very rare. It occurs only 5% of the person die of this. Very rare, hardly. And whenever there is tumor, majority are benign, not malignant. There is hardly 1 or 2 malignant ones. Most common cardiac tumors in the descending order of frequency are myxomas, fibromas, lipomas, papillary fibroblastomas, and rhabdomyomas. These are all benign. Angiosarcoma is a malignant one, which also occurs in heart. I have never seen in my professional life. Honestly speaking, I have seen that things in the book, the textbook, but yes, angiosarcoma. I have seen multiple angiosarcomas elsewhere in the body. It's a vascular tumor, and we will discuss this angiosarcoma not in the heart, but in the vascular one later on today. The common tumor are all benign, as we said, and collectively account 80 to 90% benign. Okay? So we will do one by one, starting with myxomas. One thing more. The fibromas, lipomas, papillary fibroblastomas are just the same as fibromas, lipomas elsewhere. In fibromas, there is excessive fibrous tissue proliferation, but they are encapsulated. Lipomas, they are also encapsulated, but excessive proliferation of the fat cells, lipocytes. Same thing. So we are not going to discuss here. Or papillary fibroblastomas, the same fibroblastomas, they show a papillary projections. These two important ones, myxomas and rhabdomyomas, we will discuss now. Okay? But you have to remember the names at least. So myxomas are most common primary tumor of the heart in adult. So remember one thing, myxomas are present in adult, rhabdomyomas are present in children. So we have two different discrimination. If I say a person 40 years of age had a tumor in a heart, without reading further, just looking at the age, you will say that we are talking about myxoma. Or if a child 4 years of age develops some problem in the heart, ultrasound and these studies show tumor, the first thing come in your mind will be rhabdomyomas. So these are two different categories. Period. Talking about adult, myxoma. Talking about children, rhabdomyomas. They are often associated with clonal abnormality of chromosome 12 and 17 that are thought to arise from primitive multipotent mesenchymal. They arise in any of the 4 chambers, but of the heart, but 90% are located in atrial myxoma. So atrium is a common site with a 4:1 ratio left to right. Means 4 left atrium are more common than right, 4:1 ratio. But mostly they are seen 90% in atrium. So if we ask some question that a tumor present 40 years with atrial tumor, common, huh? Really? Good. Morphology usually single, one myxoma, but you can have multiple one if they are small. So the size and they are usually seen in fossa ovalis in the atrial septum. Size is less than 1 centimeter to 10 centimeter. So big. So big. They are sessile. What do you mean by sessile? Just raised. Pedunculated, having a stalk and a ball, so it can be moved. Sessile doesn't move. It just raised like this. Pedunculated, have a peduncle and a rounded thing, so it can move. Pedunculated lesion that vary from globular heart mass mottled with hemorrhage. So because in the heart, the all the time playing with the blood, so it will be mottled with hemorrhage. So soft translucent primary papillary or villous lesion having a gelatinous appearance. Basically, this myxomas are gelatinous in appearance, right? Pedunculated with having a stalk. Form is often sufficiently mobile, as I said. They move into or even through the AV wall. So when it is in the atrium with the stalk and move like, so this is atrioventricular wall. So go in, comes out, like this one. It's very dangerous. Sometimes it is stuck in between atria and ventricle. Syncope, patient fall down, heart stops working. So during the systole, causing a wrecking ball effect. So if you see with the stethoscope, you feel a wrecking ball effect. No, with the loved up song, you see or hear some extra effect of this one, causing damage to the wall leaflet, because something which is continuously being hitting the wall will cause some damage. So this is how it looks like. This is the gross appearance. This is called mottled with blood. So a blood is almost put on it. This might be about 4 centimeter mass. This is atrium, this is ventricle. So it is present in the atrium. And if it is pedunculated, it can move in and out. Atrioventricular wall, right? And sometimes it causes syncope. Now microscopically, there are stellate shaped cells like this one, this one, this one. These are stellate shaped cells, and something like some vascular channels, which is this stellate cells will be scattered in abundant. This is mucopolysaccharide. So this meshwork is a mucopolysaccharide stellate cells. Then we have some of the vessel-like or glandular-like structures and mononuclear cells surrounding around, right? So this is basically a characteristic microscopic feature of myxomas. Mucopolysaccharide background, stellate shaped cells, glandular structures or blood vessels, plus mononuclear cells. This is myxomas. Clear?
Yeah.
Then clinical features. The major clinical manifestation are due to valvular ball wall obstruction, as I said, or embolization. If some of the pieces of that myxoma goes out, it can go anywhere in the body as an embolitis. Or a syndrome of constitution symptoms of fever and malaise. So these patients may have fever and malaise. Sometimes fragmentation, embolization can go anywhere. As I said, syncopal episode, when it blocks the vital wall orifice. So when it is stuck on a wall between, what will happen? The patient will be suddenly heart blocks and he fell down. And then as he falls down, the myxoma goes out from the wall and again the heart starts pumping. Echocardiograph provides the opportunity to identify this is a non-invasive procedure. Surgical removal is usually curative. So if you just because if it is sessile, probably it will not do any harm. But if it is pedunculated and sometimes it obstructs AV wall, then it's better to take it out surgically. Okay? Sometimes this neoplasm recur again even after you do surgery. After a few months or year, you see again myxoma develops. Rhabdomyomas, another benign tumor. This is second one, commonly seen in children. Most frequently, primary tumor of the heart in infant and children, and are frequently discovered in the first year of life because of obstruction of wall, orifice, and cardiac chamber. So when it is present near the orifice, it can cause problem. So cardiac rhabdomyomas are often associated with tuberous sclerosis. So the gene which defects is tuberous sclerosis 1 or tuberous sclerosis 2. These are the tumor suppressor genes. So this will confirm that the patient is suffering from rhabdomyomas. Because they often regress spontaneously, rhabdomyomas are considered to be sometimes to be hemorrhagic. Hemorrhagic means they are not true tumors because they regress spontaneously. So they say probably a hematoma was there. You know about hematomas, right?
Yes.
Hematomas, they are not true tumors. It's a tumor-like lesions which regress automatically. Morphologically, generally small, grey-white myocardial mass up to several centimeters, 4, 5, 6. Usually multiple in number and evolve in the ventricle. Myxomas are present in atrium. Mostly left side. These are present in ventricles, often protrude to the chambers. Histologically, now they are composed of bizarre, markedly enlarged myocyte. In myxomas, there was no myocyte. On the contrary, it was a mucopolysaccharide background in which you see some of the stellate-shaped cells, some glandular structures, some monocyte-like cells, right? In myxoma. Here, you can see enlarged monocyte, bizarre looking. On sectioning, the abundant myocyte cytoplasm is often reduced to thin web or strands that extend to the cell's membrane, appear like a spider cell. Why? What does it mean? Basically, the myocyte has abundant glycogen, right? So when you process the heart or the tumor, sometimes what happens, the glycogen goes out of the cytoplasm. So only you see a background only without a pink color. So how it looks like, this is the rhabdomyoma ventricle, right? It's a bigger one. But if you see here, these cells are large. You see, these are myocytes. But these cells, the cytoplasm become empty. So the glycogen has been taken off during the processing. So it looks like a spider, right? Spider? You don't know spider? When our holy prophet was in Ghar Hira, right, with Sayyidina Abu Bakr, that spider, I don't know what you call in Arabic. Al-Kabut. Al-Kabut, yes. How to shrink it back? Okay. Now we are coming to vascular tumor. Vascular tumor can be benign. If they are benign, they can never metastasize, remember. In fact, are not even true neoplasm, but they are hematomas, vascular tumor. They could be intermediate, so benign, intermediate, and malignant. Intermediate they rarely metastasize. Usually we put Kapishi Sarcoma here, intermediate one, or hemangioendothelioma. Okay. Hemangioendothelioma and Kapishi Sarcoma. We will be discussing Kapishi Sarcoma, but I have taken out endothelioma, right, to make you a little easier. And malignant, frequently and early metastasis, like other sarcomas, they metastasize to lungs. Okay, and in malignant one, what you keep? Number one, vascular tumor, malignant, angiosarcoma. Angiosarcoma is a very lethal tumor, nasty tumor. Usually is present in liver. Okay. Hemangiomas, very common vascular tumor, benign tumor. Remember hemangiomas, this is the only tumor, benign tumor, which does not have what is, how will you differentiate benign and malignant? Criteria. Number one,
No infiltration
Huh?
of the, no basement membrane infiltration.
What you said? Capsule. All benign tumor has capsule, but hemangiomas, they does not have capsule. So this is the benign tumor which does not have capsule. Okay? So there are three types. One is capillary hemangiomas. Capillary hemangiomas have a small slit-like opening lined by our vessels, lined by endothelial cell. Remember, whenever we are talking of vascular tumor, they must be lined by endothelial cells, right? So lined by endothelial cell, small opening. So they are usually seen in the skin over oral mucosa, sometime in the organ like liver. Strawberry type. This is a strawberry hemangioma, seen in the face or in the head. And usually this strawberry are these start with the bud. Usually they regress when the child grow up. So they slowly and gradually they shrink down, and a time comes that they vanish away. Okay. The other one is cavernous hemangioma. As the name says, caverns, big. So the vascular channels are bigger in size. Again, they are lined by endothelial cells. They are seen in the organ, sometime in the skin. They usually cause cosmetic problem, unless in brain. If it is there in the brain, they cause problem. Cavernous hemangioma. You have to take it out because they compresses the brain structure. But if it is in the face, they only do a cosmetic problem and unusual looking spot you might have seen in some of the patients. Phylogeny Granuloma is it's a rapid growing red nodule on the skin in the mouth. Microscopically resemble granulation tissue. So suppose if somebody has a cut on a lip and it is ulcerated, you know about inflammation. The first thing you do is see is the neutrophils, and finally after a few days a granulation tissue is formed. So the granulation tissue is exactly like hemangiomas. So sometimes we just name it Phylogeny Granuloma, although it's not a granuloma. It's not a true terms, but we call it if we see a granulation tissue. So this is how it looks like. Basically, this is a true hemangioma on a tongue. And if you do see under a microscope, you can see a small capillary-like vascular channels which are lined by endothelial cells, right? Very small capillary channels. On the other hand, you see a big vascular channels, right? Now the important thing is between hemangioma and lymphangioma, you see blood, RBCs in between. If you see RBC, that will be hemangioma. If you don't see RBC, you will call it lymphangioma. This is a simple thing. The other structure will be the same. This is Phylogeny Granuloma. this person had a ulceration of the lip, and when they see under microscope, it is just like this one, newly formed blood vessel fibroblastic proliferation. So it is really very hard to call it whether it's a capillary hemangioma or it is a granulation tissue. So if you call it capillary hemangioma / pyogenic granuloma is the correct answer. Okay? If you don't know history, suppose if somebody say that I have a, this is biopsy is taken from the lip having an ulceration, you call it pyogenic granuloma. Because inflammatory process going on. But if you don't have any history and you got only a biopsy and you see such thing, you call it hemangioma / pyogenic granuloma, because you see endothelial cell lining small capillaries. But yes, here it's a big lines, big vascular channel. In between you have RBCs. This is cavernous hemangiomas. Okay. Lymphangiomas, on the other hand, we will discuss later. So lymphangiomas are 1 to 2 millimeters, capillary hemangioma. Just like capillary hemangioma, this is capillary lymphangiomas. What will be the difference? No RBCs. 90% head and neck region in a kid less than 2 years. Rarely, generally they are rare as compared to hemangioma. Hemangiomas are very common, very common. They exhibit network of endothelial line space without erythrocyte or RBCs. When large up to 15 centimeter, they are called cavernous lymphangiomas or cystic hygromas. One and the same thing, cystic hygromas, and they usually see in children, infants, newly born. And if they, if he is a good surgeon, once they take out this thing, the baby becomes absolutely alright. So lymphangiomas are basically inborn defect. Lymphangioma, cavernous, especially cystic hygromas. I have seen some of the child when I was doing my lecture, when I decided not to go in the surgical or physical department. It's better to see pathology sitting in office, looking at microscope, rather than looking at each patient, right? So sitting in the office, looking at microscope, and the pathology is so important. For example, if there is a tumor, I have seen surgeons sitting in my office. Dr. Brad, please give us report so that we can start treatment. Without my signature, until I say it malignant, they are not supposed to start a treatment. It's very important. Glomerus tumor, again a benign tumor of the vessel. It's a vascular tumor, very painful. What is glomus? Glomerus body. Anybody from the class? Glomerus body. You must have seen in your anatomy, physiology. Anatomy, I think. Glomerus bodies are basically present, the cells which regulate your thermoregulation, temperature of the body. Usually these cells are present beneath the nail bed, right? And the function of these glomerus cells, these are basically a smooth muscle cells with a specialized type of cells, and they regulate temperature. If the temperature is low, what they do? They constrict. So they conserve heat inside. If it is heat, they dilate, so that heat can go out. Okay? So this is how it looks like. It's a nail bed, it is just present beneath that one. So it's a benign tumor of the glomerus cells. Benign, very painful. It's very painful tumor. Arise from the glomerus body cells which involve in thermoregulation. Present in a distal digits, especially under the nails. Individual cells are small, uniform, just like as somebody has spread some marbles around the cuboidal nuclei as scanty cytoplasm. So you can see similar type of cells here. They are around blood vessels. So these glomerus body cells actually surround blood vessels, and then they regulate blood temperature, and then they constrict blood or dilate blood vessels. Okay. Finally, coming to the intermediate, as I said, this is Kapishi Sarcoma. So Kapishi Sarcoma is a vascular neoplasm caused by human herpes virus 8 or Kapishi Sarcoma associated virus, and they are common in immunocompromised patients, or especially patients in AIDS, very commonly seen. 4 types: classic European, African, lymphadenopathic, transplant associated, or AIDS associated Kapishi Sarcoma. One by one, the chronic or Kapishi Sarcoma classic one, they are European Kapishi Sarcoma, described in 1872 by Kapishi, is a scientist who discovered this one. They occurs in old men, especially Ashkenazi Jew. So there is a specific Jew, they are called Ashkenazi. Usually they are seen in multiple part of the world, but they are not associated with HIV. Okay? Present with multiple red to purple skin papule, nodule usually in the distal lower extremities. The other one is lymphadenopathic or African type, seen in South African Bantu children, are not associated with HIV. So this is not associated one. That was not associated with HIV. Patient present with lymphadenopathy and tumor is extremely aggressive. The third one is transplant association. You know, when you do transplantation, you give immunosuppressive drugs. Occurs in a setting of long-term immunosuppressive drug. Aggressive, even fatal, with nodal, mucosal or visceral involvement. So the lesion occasionally regress when immunosuppression is stopped. So the lesion will also regress. Finally, AIDS associated. Those patients who had AIDS, originally found in a male homozygous, it can involve lymph node and viscera, and most patients eventually die of opportunistic infection rather than Kapishi Sarcoma. So Kapishi Sarcoma does not kill, but the opportunistic infection usually kills their patients. Morphology: patches, red to purple, macules, confined to the lower extremities on the foot, starting from the foot. Irregular endothelial cell lining with interspersed lymphocyte, plasma cell and macrophages. So spindle cells with the interspersed lymphocyte, plasma cell and macrophages. Raised plaque lesion, spread proximally to the and become larger. Vasculature surrounded by plump spindle cells. Again they have extravasated RBCs, macrophages and lymphocyte. They are raised plaque. The other one is patches, then plaque, means slightly raised. And finally nodularly, bigger one. Sheets of plump proliferating spindle cell, mostly dubbed slit-like opening, mild hemorrhage, sepocentric, mononuclear infiltration, and particularly seen in Africans and AIDS associated one. So this is how it looks like. This is the first initial one, plaque, not raised. But here comes up. These are macules, these are plaques, and these are nodules, right? Raised one, dome shape. And this is spindle cells. You can slit-like opening, and you can see RBCs, mononuclear cells in between. These are the mitotic figures. So these are intermediate type of vascular tumor. Finally, it's angiosarcoma, malignancy of endothelial cells, prefer skin, soft tissue, and breast and liver. They are caused by arsenic, Narotrast and PVC. No talking please. PVC are the same plastic pipes which you use in your household. Lymphedema, classically after radial mastectomy. Radiation therapy, long-term foreign body like catheter. If you put catheter for a long time, they may cause angiosarcoma. Well differentiated to anaplastic, so different variant you can see. Endothelial cell CD31 positivity. This is very important. If you want to confirm angiosarcoma, you do immunohistochemical stain by CD31. This is a best marker for endothelium. Metastasized rapidly and 5-year survival rate is only 30%. Okay. So microscopically, the differentiation is extremely variable, ranging from plum to atypical endothelial cells. Very atypical, very undifferentiated. So this is how it looks like. Grossly, this is actually ventricle of the heart, and you can see this angiosarcoma, big one, involving the ventricles. And this is the microscopic picture. You can see the endothelial line spaces, and these are larger cells having hyperchromatic nuclei. And if you stain 3D31, they are all endothelial cells show positivity. So this was all about your today's topic. Ready for your attendance now, please.